So far we've done an overview of the nursing process and then dug in a little deeper on the assessment phase and the diagnosis phase. In this presentation, we're going to look at the next phase of the nursing process, which is outcome identification, and then also into the fourth phase of planning. You'll find in some textbooks that these two are combined, and in fact the acronym ADOPE that we are using can often be seen as ADPI. So you'll see that as you poke around the internet, or if you look at other textbooks and things, that the outcome identification phase and the planning phase are sometimes combined into one single planning phase. So let's look at outcome identification. This is really goal setting or putting behavioral objectives out there for the specific problem that we have diagnosed. There's ongoing research in a classification system. You might hear this or see this written as NOC, N-O-C, which stands for Nursing Sensitive Outcomes Classification, and you'll see that in your Nursing Diagnosis Handbook. The first step in outcome identification is really establishing priorities, and you can use any number of different rubrics to help you with establishing priorities. One framework that you're probably very familiar with is Maslow's hierarchy of needs. And here's a picture that just reminds you of that our most basic needs, the physiologic needs, are at the bottom, and then needs for safety and security, and as we ascend up the pyramid we get to those needs for self-actualization. And this is a framework that can help you in priority setting, knowing that we need to address those basic physiologic needs of breathing, sleep, clothing, food, those sorts of things need to be addressed prior to being able to address any of those other needs that it might be higher in this hierarchy. Good old common sense works well also. Don't forget to just use your brain in this situation when you're looking to prioritize different outcomes. Oftentimes we'll classify outcomes as either high, medium, or low priority. And so these next slides I'll go through rather fast, and I'll let you just look at those on your own, but these would be some things that are high priority needs that require immediate action, some that are medium priority, and then others that would be considered a lower priority. They're still important, but not needing to be addressed probably with the same speed that some of the others would need. In terms of some guidelines for establishing patient outcomes, outcomes are definitely derived from the nursing diagnosis. They need to define specific behaviors that demonstrate that whatever problem it is that we've identified has been corrected or modified or prevented. So you kind of ask yourself, how will I know that the patient's response has been changed? Outcomes need to be documented as measurable goals. The subject of the outcome is always the client. The verb should be an action verb, and in fact on the next slide I will advance forward and just show you some good behavioral verbs that can be used in setting client goals. We'll back up here. There might also be conditions or modifiers on that verb. For example, we may have a verb ambulate, and then a condition on that verb would be with a walker or with assistance. So we're modifying the verb. That doesn't always take place, but that's something that we want to look at and see if that's something that needs to be in our goal statement to make sure that it's measurable. Another piece of our goal statement is to include a performance criterion. This tells us to what extent a change will be seen. If I go back to our example of ambulating, how long? How far? Do they just need to walk to the door and back in their room, or do they need to walk to the end of the hallway and back? So that would be considered a performance criterion. We also need to keep in mind time frame. Time frames should be very limited and specific. They should say within 4 hours or on the first post-op day. Those would be very short-term goals. They can be long-term, such as within 3 months, within 6 months. We see those more likely in a home care setting or a rehab setting. They may call for a more broad time frame, such as by the day of discharge, and maybe we don't know when that is, but we establish a certain outcome, certain behaviors that we want to see the client doing before they are discharged from the hospital. Some other outcome guidelines. Whenever it's possible, goals should be mutually formulated between the patient and the nurse. Sometimes our goals are not well aligned with the patient's goals, so we need to make sure that we're working together with our patient and make sure that we're all on the same page. If we include the patient in that process, the likelihood of them achieving that outcome goal is much higher. Another principle, outcomes need to be realistic in relation to the patient's present and potential capabilities. We need to consider a number of factors here. What is this patient's cognitive ability or their education or their emotional status? Perhaps we would have the same outcome goal, but it would be modified to include the words with assistance in somebody who it's not realistic to expect them to be able to reach something independently. Outcomes should also be attainable in relationship to what resources are available to that patient. We need to consider financial factors, capability of a caregiver, perhaps in a home setting, other resources that may or may not be available. So those are just some guidelines in helping us when we're writing out our outcome statements, when we're setting those goals. A great rubric that is really helpful in making sure that our outcomes are appropriate is to ask, is that outcome SMART? S-M-A-R-T. And that includes, is it specific enough? Is it measurable? Is it appropriate? Is it realistic? And is it timely? So anytime you see an outcome goal, you want to look at that and say, is that outcome SMART? And if not, what do I need to do to smarten it up? So here's just a little exercise for you. There are 2 outcome goals here. They're both great goals. The patient's hydration will improve and improve muscle strength. Now I want you to take a little bit of time, just pause this and take a little bit of time to think about whether these are SMART, and if not, how would you rewrite them to make them SMART? Okay, I hope you've taken some time to look at those. When we look at number 1, the patient's hydration will improve, we would all agree that that's a good thing, that the patient would have improved hydration. But it's not specific, it's not observable or measurable. So perhaps we would think about rewording that outcome goal to say the patient's fluid intake will be 2.5 milliliters every 24 hours. That's something that we can measure. It's timely, seems appropriate, and doable. Number 2, the same. It's not specific. There's no subject. We haven't specified that it is the patient. And there's no real criteria there to document whether muscle strength has improved. So you might try something like the patient will lift his own weight using a bed trapeze by the time of discharge. So we've assessed, we've gathered data, and we've come up with a problem statement. And based on that problem statement or diagnosis, we've set a goal or identified an outcome for where we want that patient to be. So the next piece is the planning phase, the 4th phase of the nursing process, where we plan our interventions. Nursing interventions are specific strategies designed to help the patient achieve outcome goals. So every intervention that we do as a nurse should directly relate to an outcome goal. A great place to look is look at our nursing diagnostic statement and look at the etiology. It is just common wisdom that anytime you want to address a problem, the best way to fix that problem is to go to the cause or the source of the problem. So the etiology really gives us the cause for that specific problem, and it will help to drive our interventions. So for an example, we might have two patients who have a problem with anxiety. Perhaps you have a patient, John, who's going for a procedure, and he's very anxious about that procedure. And in talking to him and gathering more data, you realize that he really has never been taught about that procedure. He doesn't know what to expect, and his anxiety is related to really that lack of knowledge. You can have Jane, who's going for the same procedure and also feeling anxious. And in talking to her, you realize that she's had this procedure many times. She knows all about this procedure. But what happened to her the last time she went to that department for a procedure, she got left out in a hallway by herself for an extended period of time. And she's really finding that she's not trusting the healthcare professionals to make sure that she gets into that procedure in a timely way. So both of them are experiencing anxiety. That's their problem. But when you look at the cause or the root or the etiology of their anxiety, it's very different. So their signs and symptoms may be the same. Some interventions might be the same, but some might be different. So for John, we're going to do some teaching, and that's going to be a major nursing intervention for us. Whereas for Jane, maybe we need to establish a strong relationship with her and then assure her that someone is going to be with her and not leave her alone. So because the root of their problems are different, even though they have the same problem, the root of their problems are different, then our interventions are going to be different. Interventions are to be based on scientific rationale. And that's something that as you go through school, you're going to be including on your care plans is the rationale behind any nursing interventions that you choose. Just like the outcomes are classified in a taxonomy, there is also what's called the nursing intervention classification, a taxonomy of research-supported interventions, and those are referred to as NICs. So far we have NANDA, NIC, and NOC for our little acronyms here. And you will find if you spend a little bit of time looking through your nursing diagnosis handbook, you will find under each nursing diagnosis the NOCs and the NICs associated with that particular diagnosis. That too is ongoing work. Lastly, we just want to make sure that when we have a plan in place, it is well communicated. We all want to be on the same page. And what we do with our plan is write out a written nursing care plan. We want to make sure that we're very specific, because a lack of specificity creates potential for miscommunication and misinterpretation and can lead to incomplete care or to mistakes. So the written care plan really serves as a guide, not just for us as an individual nurse, but for the other nurses to follow. And it really helps to promote continuity of care. Too often, that care is not well communicated, and we see problems with increased expense, inefficient use of staff time as we're repeating work that others have done, and ultimately bad outcomes for our patients. So that is the last piece of the planning, is to make sure that that is well written in a nursing care plan.